Welcome to the EAU podcast series, Present and Future of Diagnostics in Prostate Cancer. In this last episode, we are joined by Dr. Marcin Miszczyk and Professor Wolfgang Fendler. Together, they will explore the current status and future potential of PSMA-PET imaging. Join us as we embark on this informative journey.
Hello, everyone. My name is Marcin Miszczyk. I'm a radiation oncologist from Medical University of Vienna, very much focused on the subject of prostate cancer treatment. It is an honor to be here on this podcast. Thank you for this opportunity. I will have a pleasure to speak with Professor Wolfgang Fendler, one of the biggest authorities when it comes to PSMA-PET in the whole world, about how can we implement this novel imaging modality into clinical practice. Professor Fendler, would you like to introduce yourself?
Sure. Thank you very much. It's a pleasure to discuss PSMA topics, and thank you very much for inviting me. I am currently vice chair and attending of nuclear medicine in the Essen Nuclear Medicine Department. And as you mentioned, one of my focuses is PSMA imaging and treatment and in diagnostics in general. Thank you very much. Really looking forward to the discussion.
Let's start with a quick introduction of what PSMA-PET brings in comparison to the conventional imaging. I think one of the pivotal trials we had was the proPSMA trial. In this trial, conventional imaging was compared head-to-head with PSMA-PET, and it showed that we can expect both higher sensitivity, especially higher sensitivity, but also better specificity. However, there is an ongoing question whether this finding is enough to bring it into practice, or should we actually seek an improvement in treatment outcomes. There is also, with the stage migration, a risk that we will overdiagnose some patients, and some of those patients who could theoretically benefit from a standard local or local regional treatments would be rather treated as metastatic and never receive the chance for a curative local treatment. However, I think that maybe the bigger concern is actually the sensitivity. While in a proPSMA trial, the authors shown a really nice high percentage in another approach by a team of Hope et al. It's an article published in JAMA Oncology in 2021, which I believe you were part of that investigation. In this article, compared to pelvic lymphadenectomy in patients with clinically localized prostate cancer, high or intermediate risk, the sensitivity for the detection of the regional lymph node metastasis was only 0.4, suggesting that there's a lot of lesions that we are still omitting. Do you think that we have currently evidence that PSMA could improve outcomes? What do you think, for example, about the findings, the preliminary findings of the ORIOLE trial?
So I think what you mentioned is very important. There are two different, just going back to the proPSMA and the Hope et al., there are two different findings basically on the primary staging. They both are very good and improve conventional imaging staging to a high degree. But I believe that the accuracy is probably somewhere between the proPSMA and the Hope et al. Primary staging trial. One is around 40%, the other one is more than 70%. So I think it's probably in between. They're probably better than 40%, but not as high as outlined in the Australian trial. But still, it's good enough, as you mentioned, to have PSMA-PET on board for the next generation of treatment scenarios, such as in the ORIOLE trial. The ORIOLE trial, as you mentioned, is a trial that randomized patients in the recurrence and more progressed, more advanced setting into either metastasis-directed treatment for those patients that are on label for this versus observation and other forms of treatment. And findings in the ORIOLE trial, as you refer to PSMA-PET, showed that in a subgroup of patients that receive PSMA-PET, it's important to keep in mind that not all patients had a PSMA-PET. It was mostly conventional imaging, but in the subgroup of patients with PSMA-PET that received full coverage of PSMA-PET lesions, the response rate and the time to recurrence was very favorable and longer as compared to the other non-PSMA-PET directed radiation therapy patients. So I believe that the ORIOLE trial really shows that in the future, when PSMA-PET is readily available for planning oligometastatic metastasis-directed radiation therapy, I think this could become an entity with oncologic benefit in the future. There are several trials ongoing, have enrolled or ongoing on this topic that we need to wait for the results for. But I think the ORIOLE trial really made a first note and a first indication that this might be a very good modality combination of PSMA-PET and oligo-RT in the future.
Thank you. Yes, indeed, that was clearly a game changer, both the STOMP and the ORIOLE trial, and we can still see their legacy in our clinical practice. I would like to draw the attention to a very recent publication, or actually that's not even published yet, that was just shown on the last ESTRO meeting as a presentation. The PEACE-5 STORM trial, it randomized patients with up to 5 nodal lesions to receive either ADT plus SBRT to the PSMA-PET visible lesions or ADT plus elective nodal radiation. In this trial, we had very high expectancy that with the novel imaging, we will achieve durable disease control. However, we found that there was a huge increase in nodal relapses when elective pelvic lymph node radiation was omitted, and also a huge increment in prostate bed relapses when the prostate bed was omitted, which clearly indicates that we are missing something. We have much improved, no doubt. I'll be honest, I think that's not a question whether PSMA-PET will be the preferred modality, but when, and that mostly depends on its availability. However, we need to learn how to use it best. So that trial shows that we really are still missing a lot of lesions. I think there's also a very nice signal in a recently published trial. In fact, it was published less than 24 hours ago. The RADIOSA trial by Giulia Marvasso compared SBRT versus SBRT plus ADT. I believe about 60-65% of the patients in this trial received PSMA-PET. And you could see that even though all the PSMA or all the visible lesions were treated, there was, with the 6 months of ADT, which created an average of 9 months of castration testosterone levels, there was a 6-9 months increment in the PFS, suggesting that there were still lesions that we just did not see.
Yeah, I agree that I think in the specific scenarios of a pelvic nodal recurrence, we have noted that PSMA-PET has deficiencies. We will not be able to detect all sites of recurrence. It's certainly not the detection rate is certainly not above 80%. It will be significantly lower. And on the other hand, our currently established treatment modalities, pelvic nodal radiation and plus minus hormonal therapy is very effective, is a very good treatment that covers most of the disease spectrum. So I'm not sure if PSMA-PET will, in this scenario, as you outlined, seen in the STORM trial, will excel and will change the game entirely. But I think where it can definitely make a difference is selecting out those patients that have a distant phenotype, so the disease is outside the pelvis already, as maybe several lesions that cannot be captured by local radiation therapy, demanding a more intense systemic treatment. That is one thing, and the other thing is the kind of an ORIOLE-like setting where you have a local and distant metastatic recurrence, and we attempt oligo radiation therapy to those lesions. I think this combination, it could be an interesting entity in the future. But I agree with you that the local radiation therapy, the current established therapy protocols for salvage radiation therapy, they are pretty effective if they are well planned and also have ADT on board. And PSMA-PET might not be a huge game changer in that field.
I think one of the big take-home messages from the modern salvage trials, from the GETUC-17, RADICAL-CRT, from the RIVES trial, from the SP-PORT trial, was that if we do that early enough, regardless of what we do in the imaging, the results are going to be excellent. So I think an important message is that if we have the patient with an early recurrence after prostatectomy and the PSA is still very low, we should not wait, because we have a very effective treatment that is most likely going to result in a durable disease control.
I totally agree. I think in the early recurrence setting, it's most likely disease is local or in the pelvic nodal regions that are captured by salvage radiation therapy. And it's probably those patients that have borderline lesions traveling further up to the common iliac or even low retroperitoneal space, and those patients with distant lesions that might benefit in the future the most from additional imaging, because we will capture this additional huge risk of failure of salvage treatment, and that will make a difference for future treatment algorithms.
I would like to have one very controversial question. Let's assume a patient with initially localized or local regional, so N plus disease. We have the patient, and on conventional imaging, on MRI plus CT plus bone scan, we have a patient with, let's say, T3A disease and several metastatic lymph nodes, let's say 2 or 3. And then we do the PSMA-PET and we find one unequivocal metastatic lesion. What would you do with such patient?
That's a very good question. And I think the way we handle this currently in tumor boards is taking into account or keeping in mind that we have a very sensitive imaging modality that will place an upstaging, that will lead to upstaging in a significant number of patients. So having a very accurate imaging modality and reading this even more sensitively might shift the risk, the assumed risk of a patient to an outproportionate field, and might not adequately portray the patient's risk. So in these cases, I'd rather suggest to take this as an equivocal lesion and have a follow-up on this, see the further disease course, but not call out patients as distant metastatic right away, and have them move away from potential curative treatment to palliative treatment. I think for this, we really need to be sure in the images that we have a certain distant metastasis to not have an unjustified shift of risk and shift of stage for the patient. And I still believe all those treatments have been established with conventional imaging, right? So we need to keep that in mind when we do tumor board decisions. And it's totally fair to still follow the path of local treatment if patients are conventionally local, have local disease. This is seeing distant disease on PSMA-PET is a new space for us, and I think we need more data on really translating the added extent of disease on PSMA-PET into a proper treatment and also an oncologic benefit for the patient.
Thank you for this very insightful commentary. I think that's a very sensible approach, and with this, we can convey the most benefit for the patients with no combination of novel and conventional imaging. I would like to take it further to the localized disease. Recently, there has been an article by Timo Soterik and colleagues, and we actually had a pleasure to participate in this research, looking at how PSMA-PET can complement local staging with MRI. What we found was MRI, of course, is better at local. But if we combine the two modalities, we can get a little better sensitivity or specificity. But sensitivity can be improved for T3A and T3B characteristics. Now, my question is, if we take that further with the concept of local disease-directed dose escalation radiation therapy that has been shown by the group, the FLAME group, with the FLAME trial and HypoFrame trial, currently, this is based on MRI, but do you see a potential for using PSMA-PET for dose escalation, for intensification, for targeting metabolically active lesions in the prostate, making it even further personalized treatment for those patients at high risk and very high risk of recurrence?
Yeah, absolutely. I see this possibility for the future. I think the hypofocal trial that is ongoing in Germany is also looking at this concept of applying an extra boost to metabolically active regions. So this will give, in a randomized setting, will give us very good data on whether this concept might be, in terms of efficacy and toxicity trade-off, beneficial for the patient. In general, I believe that it's true. PSMA-PET can detect, can add some more accuracy to local staging. MRI is the lead modality, but PSMA-PET can contribute even in the local staging modality, especially when it comes to involvement of seminal vesicles, the T3B stage, because those might be unremarkable on morphologic imaging, but they might really light up on the images on PSMA-PET. The question is, what does this mean if we have T3B stage on PET? And I think there are very good data that and findings that we could publish last summer in Lancet Oncology. Looking at the standardized reporting of PSMA-PET, we found that in patients with a T3B stage, they have a higher risk of death along their disease spectrum, looking into a long follow-up of up to 10 to 12 years. they have a higher risk of death under the further disease course. So I believe that the local stage is important, that an upstaging to T3B or T3A is also important in patients, and that if PSMA-PET can contribute to this, it will be a meaningful contribution for future treatment planning. How should we place PSMA-PET in that clinical scenario currently? The German guidelines will shift in the next few months and will recommend PSMA-PET imaging in patients with initial high-risk disease. And I think that should be consensus internationally currently, that if someone has high-risk disease or high-risk patterns on MRI, patients should receive an additional PSMA-PET for the reason you outlined, have a better T3, better local staging, but also having this additional detection of metastasis in the pelvis and outside.
That will be absolutely amazing, and I'm really looking forward to it, and perhaps even further extending it to intermediate risk patients. But hopefully even then we can extend it to the PROMIS high and intermediate risk patients and guide the treatment with that data. Especially now that we have a lot of tools in our shed with the STAMPEDE G-arm showing that the addition of ARPs significantly reduces mortality in patients at very high risk of recurrence and the focal bus. I think that we are looking forward to a very bright future, and we're going to really improve the treatment for those patients who harbor the disease at high or very high risk of recurrence. Thank you so much for this amazing talk. It was wonderful.
Thank you very much. Thank you very much for having me for the discussion. I really enjoyed it.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.